started here. All right, I will mute myself and let you take it away.
Thank you, and thank you so much for that kind introduction and everyone for joining me today. So I just want to introduce myself. My name is Dr. Reena Lovinsky. I work in Scarborough in Toronto. I've been mostly dealing with the pandemic for the last 2 years, so I fully appreciate this opportunity to talk about something different than COVID. And I hope you do as well, even though we're all in midst still of the Omicron wave. So I do infectious disease consultation. And then I also do infection prevention and control, as well as antimicrobial stewardship at the Scarborough Health Network. Next slide, please. And as I mentioned, I'm in Toronto, so I just wanted to do a land acknowledgement to start. So I acknowledge the land I am sitting on today is the traditional territory of many nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. I also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississaugas and Chippewa bands. Next slide, please. So I wanted to just start my presentation making people aware that I'm really going to be speaking of Western ways of medicine, but the real goal of this talk is Edu-Tumunk, meaning two-eyed seeing. And what we really want to do together today is learn from indigenous ways of knowing from one eye and Western ways of knowing from the other eye, and use the strengths and gifts and insights from both traditions to gain a well-rounded perspective. Next slide, please. So I want to talk a little bit about general skin health in rural communities, talk about a culturally sensitive approach to dealing with skin health, talk about skin and soft tissue infections. If we have time as well, diabetic foot infections. I have quite a few slides, so we'll just see how time goes. I'm happy to take questions at the end or in middle. You might want to just put them in the chat as you think about them. And then at the end, we can have a discussion. And I might be available to come again in May. And I was thinking, as people are listening, they can think about the utility of the next time I come back to actually email me photos of skin and soft tissue infections. And then we could go through the cases to have a real discussion about real patients that you're dealing with at the time. Next slide, please. So, you know, when I'm preparing for this talk, I tried to look about information about skin and soft tissue infections in Indigenous communities in Canada, and really there's a lack of information. And we know that the skin is a manifestation of both internal and external health. And we know that Indigenous populations face unique challenges. There's a lot of barriers, as I'm sure you're all aware, of dealing with communities that live in isolated areas that don't have access to hospitals, that don't have frequent access to physicians, when they have chronic conditions like skin diseases and then skin infections. And what we really want to do is not just learn about antibiotics to treat infections, but build in communities a way of ensuring that there's skin health. And so I think it's above and beyond the talk today, but really part of managing skin diseases is really working with the community, because just giving antibiotics alone is definitely not enough. Next slide, please. So when we talk about healthy skin, we really want to keep it simple for our patients. We want to be proactive in terms of managing skin health, I'll talk about a few strategies during today's talk. And we want to address people's underlying health that affects their skin. And part of what you can do is actually just arranging follow-up, which may be hard and may have to be remote follow-up and not in person. But the idea is always with medicine, when you follow up with people, you can see if your strategies are working, and you can also support people in how they're using your strategies. There's a lot of skin treatments that are covered by non-insured health benefits, and it's important that everyone on the line knows what those are, so that physicians and nurse practitioners can be prescribing things that are covered. Skin treatment and even just moisturizing is quite expensive. And if there's a household problem, we want to treat everyone in the household. And another key message is, if you're treating things like eczema, you want to give people tubs, not tubes, meaning you want them to have lots of treatment available. If you give a small tube, then people are going to run out of treatment very quickly. Next slide, please. So this is just something I got from a study in Australia. There's a lot more research and a lot more support for Indigenous communities in terms of their skin health in Australia. And this was a study where they worked in a rural community and really tried to improve things by working for quite a long time. And what they were doing is observing the community, finding out the problems, sharing together ways of improving things, acting on those issues, and then observing if what they did had an impact. And this is something we can use in Canada, we have similar issues to rural communities in Australia and similar problems. So I thought this was just a good study to share. Next slide, please. And when we think about skin health and bacterial infections, this is from the study in Australia. But one of the key things when you're dealing with families is to find out how children's skin infections are affecting the child and the entire family. So children who do have a lot of eczema, both in Indigenous communities in Australia and in Canada, have a lot of pain, stigma, social exclusion, and can't get to school because of skin infections. And it's important to find out from parents which strategies are working and which aren't. There's a lot of things in medicine we tell people to do, but if they're not compliant, it doesn't help them. And part of the problem in Indigenous communities in Australia, which is similar to some of our communities in Northern Ontario, is not having access to showers or baths, not having enough towels, not having enough bed linen, not having enough laundry facilities. Not being able to wash bed linen and towels is a significant barrier to keeping skin infections at bay. And it's really important that we ask about traditional remedies, because we want to use traditional remedies as well as Western medicine when we're approaching these families. And one of the problems that I'm sure is the same in Indigenous communities in Canada as Australia is people start to think as skin infections as normal. They need to be educated that they're not normal and there's a way to treat them, and also that they shouldn't have to live with these skin infections. Next slide, please. So why do people in rural communities get skin infections? One of the concerns is that many children have eczema, much more than in the south of Ontario. And eczema, or atopic dermatitis, is a big risk factor for skin infections, mostly because people are scratching because they have breaks in the skin, and breaks in the skin is how bacteria on the surface of the skin get underneath and cause infection. Poverty, obviously, if you're not eating well, if you don't have good nutrition, is always a risk for infection, but it also means you can't afford treatments. When you have crowded housing conditions, if one person has impetigo, they can pass it to someone else. And as I mentioned, the cost of moisturizers and skin treatments are very expensive. And obviously, if you don't have access to clean water, that's a huge issue to trying to prevent skin infections. Next slide, please. So what is eczema or atopic dermatitis? It's a skin condition that's very common in children, especially in the north, where there's persistent itching and scratching. And it can affect sleep. When people are itchy, they're distracted during the day, but at night when you're trying to sleep, there's no distractions and you start scratching. You can even scratch in your sleep, and that break in the skin is a problem. It can affect your mood, it can affect your self-esteem, especially if eczema is on your neck or on visible body parts. Children can be cruel, and having changes in your skin can affect your self-esteem. It can affect your self-image, it can affect your friendships, it can affect school and work performance. And it can be associated with anxiety and depression. So adults can miss work or children can miss school just because of eczema alone. And it may make children afraid to participate in sports if they have to be wearing shorts or t-shirts where their skin disease is visible. Next slide, please. So this is just a website that was made actually from Sick Kids, which is the Children's Hospital in Toronto, which has a lot of good information about eczema to share with your patients. So there's just some pictures of what eczema can look like. But I think what we need to educate our patients is eczema is a chronic disease. It can't be cured, but it can be managed. And the key is to not undertreat, but actually overtreat in terms of actually preventing triggers and moisturizing, but also recognizing that eczema can affect people's lifestyle, and that we want to encourage children to still be active and be in sports, but really that they need to know what triggers their eczema and making sure they can try and avoid flares as much as possible or treat flares early so that they don't become a bigger problem. Next slide, please. So winter skincare, this is important for everyone on the line, all of us and for our patients. Now that it's still winter, even though officially it might be spring, it's still quite cold. Low humidity, cold air can lead for everyone to itchy, painful, dry skin. And it's important for people to try and protect their skin from winter elements, especially their hands with gloves. If possible, having a humidifier at home can protect your skin at home from the dryness. And it's very important, especially for children with eczema, to moisturize after they wash their hands or after they bathe. And what you really want to encourage people to do is have oil-based moisturizers that are fragrance-free. Things without fragrance are more gentle. It doesn't have to be some fancy brand name. Anything is good. And then bathing for short periods of time. And this is a hard one in the winter, but to encourage people to use warm water, not super hot water. So as much as hot water feels good, it dries out your skin. And when they're done bathing or even washing their hands, the idea is to pat your skin dry. You do not want to be rubbing with a rough towel on the areas where you have eczema. And while your skin is a bit damp, that's the best time to apply moisturizer. It seals in the wetness from the shower or the bath into the skin. And you want to apply, you can never apply too much moisturizer. So as long as you have something people can afford, they can apply it liberally and frequently. Next slide, please. So what I really want to emphasize, which I'm sure you all know, is when we're dealing with our patients, we really need to have a cultural approach. And these are lessons learned from Australia. It's really building relationships, not just with your patients, but in your community, with the school, if there's a health clinic, and really where children live, learn, and play. And a lot of medicine is not just drugs, but it's connecting with communities and families and making it a community approach. So being part of storytelling circles, acknowledging our connection to the land, acknowledging that there's transgenerational trauma, which can affect all matters of illness. If parents are depressed or have anxiety from previous trauma, that affects how they can support their children. And we want to empower, consult, and engage our communities. So this takes time. The same with the first slide I showed about the Indigenous communities in Australia. We can try things, but we have to take time to build relationships, trust, and respect. We want to encourage people to use traditional remedies and then have child and family-centered approaches. Next slide, please. So I thought I would just show a medicine wheel. We know that this shows that we are acknowledging where we're from, where we're going, and honoring the space we're in. And we can use this idea to really have an interconnected way of approaching skincare. Next slide, please. So we want a multifaceted approach. We want to look at school-based programs, community-based programs, the social determinants of health, and our health services. Next slide, please. So these are really information from the literature in Australia. As I mentioned, there's not great literature in Canada. We want to look at the health services that are available in our communities and make sure we're using our Indigenous staff to build interactions with the entire family. And really with skincare, we want to be proactive and we want to follow a chronic disease model, which means close follow-up. And we also need to be able to advocate for children who don't have a voice. And the best thing we can do if you can access your communities on a regular basis is have peer educators. So if you educate a community champion, that person can do your job while you're not able to be there. Next slide, please. And then we want to have school-based education. So teachers also need to have a lookout and understand about skin infections and skin health. Children are in school during the day. Teachers have access and see the children all day long. They may notice things that parents don't if they're busy at work during the day. So school educators need to have a role, as well as if there is a school nurse. And we really ideally would want to use the school to support the entire community. So in Australia, they encourage schools to buy washing machines for clothes. So if families didn't have laundry services at home, they could share the one in the school to use for their personal use. Next slide, please. And then obviously, as I mentioned, community-based. You know, some places social media may be helpful, but what we really want to do is educate families in the community that skin infections are not normal and that they need to be treated. And that if parents are educated and the community has buy-in, especially the elders, we can further support families in real time on a daily basis. Next slide, please. And then we know the problem with skin health is what affects all Indigenous communities is the social determinants of health. So not everyone has access to laundry, not everyone has access to soap. We need to support our families with laundry detergent, with soap, so that they can do the things that will protect their skin. And if there are options to help with transportation so people can obtain medications and hygiene items, we really need to use the government support and public health support to help with the social determinants of health. Next slide, please. Things that don't work is a one-off strategy. So what we really want to work on is sustainable strategies. So we need to have something that the community can be champions on their own and continually work on. Telling people that their home has to be clean does not work. We all know the work-life balance. It's impossible when you're working to have a clean home. And we just want to recognize the barriers that people have to keep their home clean or to be able to do laundry. And we never want to be judgmental about people's parenting skills. Everybody is doing their best. And parenting is challenging. And a pamphlet about good parenting is really just judgmental and doesn't really understand the complexity of trying to parent, balance work, and balance the stresses, especially during the pandemic. Next slide, please. So I'm going to talk a little bit about the Western approach to skin and soft tissue infections. A lot of this is practice we do in Toronto, which is a little bit different in Indigenous communities. So I'm going to speak to that as well. Next slide, please. So there's different layers to the skin that can all develop infection. So if we think about the layers of the skin, the outside layer is called your epidermis. So our skin is actually fantastic. It's waterproof. You know, you go swimming and water doesn't enter your body. But if there's breaks in the skin, bacteria can get under the surface and cause problems. So we have bacteria on our skin 24/7. It's not causing a problem. It just lives on us. But when there's a break in the skin, it can cause infection. So infections on the surface of the skin, some of them are erysipelas, impetigo, and folliculitis, which I'll talk about in a minute. And then there can be infections that are deeper under the other layers. So cellulitis is much deeper than erysipelas. And then necrotizing fasciitis, or colloquially known as the flesh-eating disease, is much deeper. And you can even have infections of the muscle. So infections can start on the surface and go deep. Infections can start deep and come to the surface. Next slide, please. So impetigo is very common in Indigenous communities. So I'm just going to concentrate on this for a little while. So impetigo is an infection, as I mentioned, of the outer layer of the skin. It can look like single or multiple pustules. Pustules are like little pus-filled blisters. And when they rupture, you can see a golden crust. So one of the common bacteria that cause impetigo is Staph aureus, Staphylococcus aureus. Aureus actually comes from the Latin for gold. And it's really because of impetigo that golden crust is classically from Staph aureus, or being gold in Latin. And it most often happens in areas that are exposed, so face, arms, legs, and often seen in babies, young children, and young adults. And because it's on the surface and there's the pustules that rupture, that pus that's on the skin can go from one person to another. Next slide, please. So usually it's caused by group A strep or Staph aureus. These are two skin bacteria that we most often have, and they cause actually almost all skin infections. So group A strep or Staph aureus can cause impetigo. Usually, if it's localized to a small area, you can just use topical antibiotic cream. So mupirocin is a good one. It covers not only Staph aureus, but methicillin-resistant Staph aureus. It'll also cover group A strep. But if it's an impetigo situation where it's on so many areas of the body that will be impossible to cover with cream, you can use oral antibiotics. Now in Toronto, we would use Keflex or cloxacillin, but in Indigenous communities, if you think your community has a lot of MRSA, which may be most communities, you would really be using Septra or clindamycin. So Septra is an antibiotic that treats most MRSA infections. It's usually well tolerated. Very rarely, it can cause Stevens-Johnson syndrome, which is a skin inflammation that is quite severe and serious. The problem with clindamycin is it's a high-risk antibiotic for causing Clostridium difficile. So all antibiotics can change the healthy gut flora, and then Clostridium difficile can overgrow and cause diarrhea. So I would usually probably use Septra if you know that the MRSA in your community is sensitive to Septra. And I'm going to talk about MRSA in a few slides. So in terms of antibiotics, Keflex or Clox, if you think it's not MRSA, Septra or Clinda if you think it is MRSA. Next slide, please. So how do we stop impetigo from spreading in household? As I mentioned, those crusts and that pus is contagious. So people are contagious as long as they have open blisters and sores. So we really want to try and keep them covered either with clothes or dressings. Or if someone's been on antibiotic for 24 to 48 hours, they're no longer considered contagious. So what we want to do is try not to touch the areas that have pus on them and sores. And we want to try to not have other people in the house touch those areas that are crusty or full of blisters. So at the time where a child has impetigo, we really don't want them sharing toys. We don't want them sharing bath towels. And we want to try and keep the sores clean and covered, which is easier said than done. Next slide, please. So if someone has impetigo, we want to make sure they're always washing their hands, especially because we know kids are going to be scratching the areas with impetigo, they get itchy. We want to make sure that when they bathe, they use a clean towel or a clean washcloth if they're washing their face. So this is also difficult to implement if you don't have a lot of laundry service. If you're trying to wash your face and bathe daily or every other day, that's a lot of towels and washcloths to have for laundry. Ideally, you want to wash all the clothes and bed sheets the child has used while they're infectious. and wash everything in hot water and wash their clothes separately from other people's clothes. Also hard to do in Indigenous communities. And you want to just keep the house clean if possible. And one of the key strategies that's easy to do is make sure the child's nails are trimmed short. So the shorter your nails, the less damage you can do when you're itchy. And if children are too itchy and can't stop scratching, you can put on calamine lotion or anything else that will ease the itching. Next slide, please. So how can we prevent it from happening again? We can treat wounds early. We can try and encourage children after they practice sports to bathe or shower, making sure children are washing their hands, trying not to share sports equipment, towels, and clothes, making sure people aren't pulling dirty clothes out of their laundry hamper, especially if they use them for sports. And then if someone has impetigo, trying to avoid touching the person's skin or avoid touching things that that person has touched. Next slide, please. So folliculitis, I'm just going to switch topics for a second. Folliculitis is inflammation of a hair follicle. So we've all seen people where they have these tiny little red bumps where they have hair. So this can be for men on their chest, especially if they've been doing sports and they've gotten sweaty, face, arms, upper back, lower legs, also something that can be itchy. Folliculitis, we try not to treat with antibiotics. We just recommend good hygiene with soap and warm compresses to the area. But if the lesions develop into an abscess, then what we really need to do is have incision and drainage. Next slide, please. And then briefly, just to talk about erysipelas. Erysipelas and cellulitis are very similar infections. Erysipelas is in that top layer of the skin. So you see a well-demarcated edge. That means you actually, it's almost like a line at the edge of the skin infection. Classically, it happens on the face. Classically, it's from group A strep, but it can also be from Staph aureus. And really, it's not important at all to distinguish between erysipelas and cellulitis. The treatment is exactly the same. Cellulitis and erysipelas, you need to treat with oral antibiotics. In Toronto, we would usually use cloxacillin or Keflex because it's group A strep or Staph aureus.
I do believe that I will be able to get you.
If you're worried about Staph aureus, and what you really want to do is make sure, if you're worried about MRSA, to treat with Septra or Clinda. Next slide, please. And then cellulitis, you can see in the picture, it's a little less clear the edges because it's a deeper layer of the skin. Sometimes you can have enlarged lymph nodes. So if it's on the legs, you might have swollen femoral lymph nodes. If it's on an arm, you might have enlarged lymph nodes under your armpit. And same thing, Clox or Keflex if you're not worried about MRSA, Septra or Clinda if you are. And with cellulitis, what's really important to note is it gets worse before it gets better. So we worry about, I'm going to explain about necrotizing fasciitis, but with cellulitis, even on the right antibiotics, even though antibiotics work right away, we don't see clinical improvement for about 48 hours. So you have to warn people when you start treatment that the redness might spread, and then by 72 hours, the redness should start to get better. Next slide, please. So what causes cellulitis? It can just happen. If there's breaks in the skin or an injury, that break in the skin allows bacteria, as I mentioned, to get deep under the surface and cause cellulitis. Tinea pedis is the medical name for athlete's foot. So if people have breaks in between their toes, that's athlete's foot where the skin cracks, that's a risk factor for cellulitis. So that you would treat with Canesten. So you want to make sure that you check people's between their toes if they have cellulitis on their legs, because treating the tinea pedis will prevent further cellulitis. If people have lymphedema, let's say a woman had breast cancer and had their lymph nodes removed, that arm, if it has lymphedema, is a risk factor for women post-breast cancer treatment to get cellulitis, or if people have lymphedema in their legs, it's a risk factor for cellulitis. And it's very unusual for cellulitis to be bilateral. So if people's legs are both red, it's actually unlikely to be cellulitis. Next slide, please. So what could cause that redness? Sometimes when legs are just swollen, they're red. So red legs that aren't painful are very unlikely to be cellulitis. Cellulitis is painful. And another way to try and sort out if it's infection or not is to raise the person's leg. So have them lie on their bed or if you're in a health center on the examining table, and lift their leg up in the air and hold it up for a couple minutes. If you're holding it up and all the redness disappears, then that's dependent rubor. Dependent rubor is when people have peripheral vascular disease, and rubor is Latin for red. So it means with gravity, there's redness when you're sitting up and you're lowering your legs on the floor. But if you lift your leg up in the air, then that redness will disappear. And what you'll find when people are getting better from cellulitis is the swelling takes a while to get better. So the pain will get better, the fever will get better. The swelling takes a long time to get better because the lymph vessels are damaged. Lymph vessels carry water back to the heart. So after cellulitis, often you have swelling, sometimes for weeks, sometimes for months. And then people will get very worried because what they'll find is when they wake up in the morning, their legs do not look so red because they've been lying flat. The blood hasn't gone to their legs. But at the end of the day, after they've been walking, after they've been sitting, they'll notice their legs are more red. So when they go to bed, they'll be quite worried because their legs are more red. But that's really just related to position. So just to reassure people, if they can lie on their back and lift their legs up in the air and they're no longer red, nothing to worry about. Next slide, please. And for abscess, we need to incise and drain. So there's been a lot of studies in the States where there's a lot more MRSA than in Toronto, that it's not the choice of antibiotics that's important with abscess, it's really the drainage. So with an abscess, if you don't treat for MRSA, it likely doesn't matter because as long as you have good drainage, you're likely going to have improvement. And then with an abscess, it's very important after you've drained to pack it deeply. If you don't pack an abscess and you just put a Band-Aid on top, then it won't heal from the bottom up. It'll superficially heal at the surface and you'll be left with a hole underneath, and that's going to fill up with fluid again. And so the choice of antibiotics for an abscess, I would likely start with treatment with Keflex or cloxacillin. I find people with cloxacillin, it's a little harder on the stomach to tolerate. So Keflex is my drug of choice for skin and soft tissue infections in Toronto. And someone in the chat talked about doxycycline. So doxycycline is also a great antibiotic for MRSA. The reason I didn't mention it actually is I don't use it so often for two reasons. One, it makes people photosensitive, which means if it's sunny outside, they're just more likely to burn. So it depends on what's happening with the weather and how much people are outside. So if people are on doxycycline, they have to be very careful of sunlight and wear sunscreen, which they may or may not be able to afford. And then the other thing with doxycycline is after you take it, you need to sit up for at least half an hour. So it can cause inflammation of the esophagus. So actually at our Centenary site, they use doxycycline for pneumonia. They use it quite a bit. We don't use it at my site, and they don't find so much problems with esophagitis, but it is the recommendation. So doxycycline is a good antibiotic for MRSA. You have to see how it's tolerated. So the key issues to think about is photosensitivity and then esophagitis. So if people are going to take it, they have to make sure they sit up for half an hour. They're upright, even if they're watching TV, or they're just sitting up reading a book, but not taking it right before you go to bed and you're lying flat. Next slide, please. So what happens if your patient is allergic to penicillin and you want to use Keflex? It's really important to know the key questions to ask to sort out a true penicillin allergy. So people with a true worrisome allergy will have a history of shortness of breath, anaphylaxis, meaning they had to go to hospital for a severe reaction, or they may report having a swollen tongue or face. So I would usually not use penicillin if anyone had those symptoms, but people who don't have any of those serious symptoms, you can definitely challenge them with Keflex. There's actually very little crossover between Keflex and penicillin allergies. When we were in med school, they taught us not to use Keflex if you're allergic to penicillin. The risk of allergy with Keflex if you're allergic to penicillin is actually quite low. And for people who really are severely allergic to penicillin, you would use Clinda and Septra as your first line always for skin and soft tissue infections, or doxycycline, that's also not in the penicillin group. Next slide, please. So how do we know if people are really allergic to penicillin? 10% of Canadians say they're allergic to penicillin, but only 1% actually have a true penicillin allergy. And sometimes people say they're allergic, but really they had side effects. They had nausea or diarrhea or dizziness. And it's just a reminder, if you put people on antibiotics, always let them know that there are side effects to any antibiotics. People might get nausea or diarrhea or rash, and that they need to tell you if they have any allergic reactions or even side effects, especially if you're putting someone on antibiotics for a while, no one's going to be able to keep taking an antibiotic if it's causing nausea or diarrhea. So it's really important they feel empowered to contact you if they're having side effects of the antibiotic, but know that that's not an allergy. And people who had penicillin allergies as children, many of them lose their sensitivity after 10 years. Next slide, please. So why do we care about penicillin? It's just that penicillin is a great antibiotic. and less associated with C. difficile infection compared to other antibiotics, especially like Clinda. And we know that the more we use antibiotics, the more likely we are to develop multi-drug resistant organisms. So we always want to use the most narrow spectrum antibiotic we can. One, it's cheaper, so it's more affordable, but also because it doesn't cause as much antibiotic resistance as broad spectrum antibiotics. Next slide, please. So what can you do? Always try and sort out people's drug allergies even before you have to use antibiotics, so you have it recorded. You want to ask what kind of reaction they had, how long ago it was, and the key questions is what they did when they had the reaction. If they didn't have to go to the hospital and they didn't have to go to the ICU and it was just managed at home, it's really unlikely it was a severe reaction. Obviously, if you have anaphylaxis, you'd end up in the hospital. And then finding out what they took. If they took Imodium, then obviously it was diarrhea and it was nothing about hives or swelling of the face. Next slide, please. So one of the big questions for everyone on the line, which is difficult for me to advise on, is when do you need to cover MRSA? Before I did this talk, I tried to reach out to multiple people across the province about MRSA rates in rural communities. And the last data that's really been published is from 2012. And I couldn't get any more recent data. So you may know your MRSA rates better than what's published, but it's quite unfortunate that there's no literature. But we know there's high rates of MRSA in rural communities in Ontario. It's the same problem in Australia as well, especially where areas there's a lot of frequent skin-to-skin contact with people, where people are sharing potentially contaminated personal items, where it's hard to keep clean, and where there's lots of broad spectrum antibiotics because people are getting antibiotics at home and not in hospitals and might be overtreated as a just in case. Those are all risk factors for MRSA. Next slide, please. So this is data from 2012 from Northern Ontario. And you can see in 2012, it was over 50% of Staph aureus specimens were MRSA. Next slide, please. So the highest rates were actually in children 0 to 4 years of age. This is also likely the group that has impetigo. So one, it may be that they were just tested more often because they had more skin infections, but also might be age-based because their skin is uncovered and there's a lot of play with other children, so more skin-to-skin contact. Next slide, please. And that they really found a lot more cases in the summer, July and August. It's interesting, a lot of infections are more common in different months of the year. So it could be just with more sweating and more heat. There is more MRSA or even Staph aureus infections in the summer. Next slide, please. So this was also looking at reinfections and that people who are already colonized with MRSA were having a lot more infections than people not colonized with MRSA. And it could be these are people who had eczema and underlying risk factors for MRSA infections, but it's ideal to actually know the MRSA rates in your own communities because they may be different from community to community. So this data is 10 years old. I would assume that rates are still very high. You would probably know better than me, but it's quite frustrating. I even reached out to the Northern School of Medicine and no one got back to me about MRSA rates and there's nothing published for the last 10 years. Next slide, please. So in terms of choices of antibiotics, as I mentioned, it's really important to know the local susceptibility data, which I can't find, and I'm not sure you'll be able to find, especially when people have impetigo, you're not always getting specimens to culture. But in general, Clinda and Septra are good options as well as doxycycline. And if you know that your community has Clinda or Septra resistance, then you would switch it up. There can also be resistance to mupirocin. So unfortunately, I couldn't get that data, but because of the risk of mupirocin resistance, we don't really recommend trying to get rid of MRSA, decolonizing people, especially when it's in families. It's very difficult, especially when there's an outbreak of impetigo, to get rid of MRSA, especially if there's open skin, especially if people have underlying eczema, especially if people have open wounds. Next slide, please. So this is from the IDSA. This is the Infectious Disease Society of America. And this is really when to think about using MRSA. So really the worry is when to treat MRSA is when you're worried about the patient. So if you're worried they have a blood infection, if you're worried they're quite sick, you really want to start with a more broad spectrum antibiotic. But if it's a simple abscess, if you're doing incision and drainage, you probably don't need to use MRSA. If you have cellulitis, they're saying with pus or with exudate, you might want to start covering with MRSA. Next slide, please. And if, you know, they look healthy, they look good, they don't look septic, you could probably start with Keflex or cloxacillin. So I think it depends on what you know about your community. These are the guidelines for outpatient options for MRSA. Clinda, Septra, Tetra, or Doxy. I would be hesitant to use linezolid. It's expensive and definitely not to use as a long-term antibiotic. But I think it's really important to know your patient and how well you can follow up. So if you can't get back to that community for quite some time, you're not going to be able to follow up. So unfortunately, you may be over-treating MRSA as a just in case. If you can follow up, then you can see how they respond to Keflex or Clox before deciding to switch to MRSA therapy. Next slide, please. So when we have families where we have a known MRSA infection, we really just want to encourage hand hygiene, regular bathing, trying to avoid sharing towels and bedding, and let people know with any infection if they start to get systemically unwell or things don't improve within, I would say, 72 hours, that they need to seek medical attention. And as a side with MRSA, people can get MRSA pneumonias, which can be a complication of influenza. So we really want to encourage people as a preventative measure to prevent MRSA pneumonia to get their flu shot every year, which is covered by the government. Next slide, please. And then we don't, as I mentioned, try and decolonize for MRSA. I reached out to Alison McGeer, who's one of our MRSA experts in Toronto, and she really didn't recommend it. So unfortunately, it's really just treatment as opposed to get ridding or decolonize people for MRSA. Next slide, please. And then I just wanted to quickly talk about a couple other skin infections. So neck fash. How do we tell if someone has necrotizing fasciitis? Usually they look quite sick. They're going to have pain out of proportion to the redness that you're seeing on their skin. Usually the redness spreads quite quickly. So they may also have toxic shock syndrome from group A strep. So they may have low blood pressure. They may have symptoms of toxic shock. And if you're worried someone has necrotizing fasciitis, it's a diagnosis made really by surgery. So you need to send them to the hospital. Next slide, please. So early signs of necrotizing fasciitis, the rapid progression of the erythema. You might see necrotic skin, you might see bulla. Classically in the literature, the skin is numb, but I really don't see that quite often, to be honest. It's much more how much pain the person is in and how sick they look. Next slide, please. And necrotizing fasciitis is one type of an invasive group A strep infection. So there's actually more invasive group A strep infections in rural Ontario than down in Toronto. So the classic invasive group A strep infection is group A strep toxic shock. You may have heard of this being associated with tampons. So now most people use less absorbent tampons than a generation ago. So it's actually not so common with menstrual cycles and tampons. It really just happens out of the blue. People who are actually also at risk of group A strep infections are pregnant women. So prepartum, postpartum, they're more at risk of toxic shock and group A strep infections. Toxic shock is defined as shock, which is low blood pressure, group A strep in the blood, because the blood's not supposed to, is a sterile site and not supposed to have group A strep, and then multiple end organ damage. So that can be elevated liver enzymes, elevated kidney function, elevated INR, so hematological kidney liver dysfunction. Sometimes people have a red rash, so they almost look sunburnt even though they haven't been in the sun, and they can have necrotizing fasciitis. Now you can see half those things are based on blood work. So if you don't have access to blood work, it would be difficult to know if they have end organ damage, but you're really looking in general with infections. If someone has low blood pressure and they look like they're systemically unwell, you want to be sending them to hospital. Next slide, please. And then the last skin infection I just want to mention is scabies. Scabies can be very common, especially in houses with crowding. And classically, we're told to use topical permethrin. But that can be tricky in rural communities because you need to be able to shower, and it can be very uncomfortable in the summer to wear, and you need a private space to put it all over your skin. And you need what's called functional health hardware, which really means the basics of having toilets and showers and taps and a place to change. So it would be very reasonable to use ivermectin as a different option. Ivermectin is a pill and can be much easier to give an individual and their family. So you could try using topical permethrin, but you don't necessarily have to wait for that to fail. You could start with ivermectin, which just might be easier for everybody to use in a rural community. And that's just a picture of what scabies looks like. Classic scabies are little bumps between the fingers that are very, very itchy. The way to actually diagnose scabies is to do skin scrapings and then send it to the lab and they look at it under a slide, but that might not be accessible. So it's really much more the classic look of having those itchy 1 to 2 millimeter papules between fingers. And then Norwegian scabies is when everyone is covered in little bites and those papules all over their body, more common in little children than in adults. Next slide, please. So I was gonna switch to diabetic foot infections, but I feel like there's a lot of comments in the chat and I wanna leave room for questions. So I'm just gonna wonder if we should stop here and then maybe next time I can speak about diabetic foot infections and we can actually also just discuss some cases. But I'm just gonna open up to the group if we wanna stop here and open it up for questions or continue on with the next group of slides. So maybe I'll just start by answering some questions in the chat. Oh, you want me to continue? Okay, I'm going to continue and then we'll hopefully have time at the end for questions. Okay, so in terms of diabetic foot infections, these slides I can go through quite quickly. Next slide, please. Diabetes is very common, as you all know, in Indigenous communities. And classically, we would like to have a multidisciplinary approach. So when someone has a diabetic foot infection, you want an ID specialist ideally to help pick antibiotics. You need someone to help with wound care and debride the wound. You want to look at people's peripheral vascular disease and have a vascular surgeon. And most importantly, you want to manage their diabetes. So this would be the ideal approach. Not sure how much is that available in our rural communities and in a timely fashion. Next slide, please. So what happens with diabetics is they get foot ulcers and they can start from just having a superficial ulcer and develop all the way into gangrene of the entire foot. So this is just staging of our diabetic foot ulcers. As they go deeper, the grading system goes all the way up to 5. Next slide, please. So the stages can progress quite quickly. So when I started as being an infectious disease specialist, when patients would tell me that their toes turn black overnight, I had trouble believing it, but it definitely happens. And the worry is when people have blood flow issues, especially small vessel disease, then when parts of the foot, especially the toes, don't have good blood flow, things can turn black quite quickly. So when we think about the blood flow to the foot, you can think about it as a tree with a trunk and branches and twigs. So in our legs is the trunk of the tree, but all the way to the toes are the twigs. So if someone has blockages in the trunk of the branches or just the branches themselves, vascular surgery can improve the blood flow. But if the blockage is in the twigs, in the small vessels, there's nothing to do to reverse it. And you need blood to carry oxygen and help with healing. So people who have small vessel disease often have toes that turn black quite quickly. And the blackness can happen, as I'm sure you've seen, to an entire foot or heel based on blood flow and poor circulation. Next slide, please. So why do diabetics get these foot infections? Sometimes it's just from neuropathy. So with poor feeling in their foot, their joints can change and then they can have bony prominences, limited joint mobility, and all these deformities can cause problems with their footwear and rubbing. But then because what diabetes does is not only affect your blood flow, but it also affects your sensation. So if you're walking barefoot or with inappropriate footwear, you may not feel when you have a wound. So there might be something in your shoe, you might step on something, you might have something hot or cold you stepped on and you have no idea because you can't feel it. And then the wound starts and you don't take care of it early. So one of the most important things we have to tell our patients is foot education, that they need to look at their feet or have a loved one look at their feet to on a regular basis look for early wounds or injuries. Next slide, please. So as I mentioned, it's multifactorial. The neuropathy, the poor sensation, the poor blood flow, that's called peripheral vascular disease. High sugars with diabetes affect your healing. And as people have poor vision, if they're older, then they're not gonna be able to see the wounds. And most people, by the time they've been diagnosed with diabetes, actually have had diabetes for 10 years. So even if you start treatment and people are fantastic with their sugars, they already have the damage to their nerves, to their peripheral vascular system by the time they're diagnosed. Next slide, please. So in terms of how diabetic foot infections happen, as I mentioned, it's multifactorial. You have poor sensation, you have poor blood flow, you have a wound, and then that infection happens, and without good blood flow, you have poor wound healing. Next slide, please. So why does neuropathy cause diabetic foot infections? As I mentioned, you don't have good sensation, then you have the trauma. You have a wound that gets unnoticed and unchecked, and then you end up having tissue necrosis, and then you can have infection deep under the skin or superficially an ulcer, and often the wounds go all the way down to bone. And by definition, if a wound is down to bone, we call that a bone infection, osteomyelitis. Next slide, please. So blood flow is a huge issue, as I've mentioned, and it's the small and the large blood vessels. Without that blood flow, not only do you have decreased oxygen to the wound that affects poor healing, but antibiotic penetration is worse, which is why sometimes with very severe diabetic foot infections, we prefer to use IV antibiotics. But there are antibiotics that I'll mention later that are well absorbed when you take them as pills, which is an easier method in rural communities than forcing people to have PICC lines and go to hospitals or health centers for IV antibiotics. Next slide, please. So what are we looking for on physical exam? We want to look for sensation. Most of us don't carry around a monofilament, but you can just break a tongue depressor in half and use the dull end and then the sharp end to look for the ability for people to feel that tongue depressor, the sharp or the dull end. You always want to be examining your patients, their feet, and looking between the toes for evidence of ulceration, calluses. We want to make sure they have good footwear early. And if they have bony prominences or a Charcot-arthropathy, they're more at risk of getting wounds as well. And you always want to be looking for any necrosis, any areas of black or unhealthy tissue. Next slide, please. So as I mentioned on skin exam, you're also looking just for the temperature of a skin. So if an extremity is cold like ice, that foot or that extremity is dead and that person needs to go to the hospital. So cold like ice is very concerning. Everything being black is also very concerning. But in terms of when areas are black, if just toes are black, the person doesn't need to go to the hospital right away. But if you have a black, ugly, infected, pus-filled wound, you're really going to need hospital care earlier. Next slide, please. So how do we manage? So in terms of management, there's lots of M's to remember: mechanical control, metabolic control, micro control, macrovascular improvement, and medical education. So when we talk about mechanical control, we really want to look at people's footwear. Metabolic control, when people have diabetes, their sugars go out of whack when they have an infection. They go high. So we want to make sure they're checking their sugars and controlling their sugars. Microbiology is making sure we're on the right antibiotics. Getting them to a vascular surgeon if that's available to improve things for the wound itself to heal and also for the future for prevention of further wounds. And then all the education about what to look for. So when you see the patient, the wound might be superficial, but if you can't get back to that community for quite some time, you want to educate people on what worrisome signs they should look for. So, you want to educate the family that if the patient looks systemically unwell, they need to seek medical attention. If the wound is worsening, if they look like they have an abscess, they're going to need medical education. You want to think about what they can do to be what they need to look for when you can't be there. Next slide, please. So in terms of antibiotics, as I mentioned, we worry about osteomyelitis. So by definition, you don't need an X-ray, you don't need an MRI. If the wound probes to bone, by definition, it's osteomyelitis. So you can just take a wound swab, and if you can probe that Q-tip down to bone, if you feel bone, you have bone infection. So classically in the literature, we give IV antibiotics for 6 weeks for osteomyelitis, but that's not always the easiest thing to do in rural communities or even in Toronto. And a PICC line is a huge headache for patients, and they may not be compliant with IV antibiotics. So you can use oral antibiotics even for osteomyelitis. Ideally, you really want to have some sort of culture to help guide your infection. But the trouble is when you do superficial swabs, you may not be able to get real bone biopsy cultures. It's the bone biopsy that would give you the best cultures to know what antibiotics to use. So if your patient's in hospital and having surgery, if they can get a bone biopsy, or if a plastic surgeon is debriding things, that bone biopsy will guide your antibiotics. Otherwise, you have to look at the wound and make a decision. So sometimes diabetics just get an abscess. So if it's just an abscess on their foot, it's classically caused by Staph aureus. So depending if you're worried about MRSA or not, what you really want to do is have that abscess debrided, and you can definitely start with Clox or Keflex. but use Septa or Clinda if you're worried about MRSA. So an abscess is unlikely to be polymicrobial, but a wound, an ulcer or osteomyelitis is. So a good option for oral antibiotics would be clavulin. That has pretty good bioavailability. You can also use ciproclindaflagyl. Cipro will cover most Pseudomonas, depending on the sensitivities. Clinda will cover your MRSA and Staph aureus, and Flagyl will cover anaerobes. Clinda Cipro, though, is a high-risk combination for C. diff. So I don't have it on here. I don't usually use it, but we don't have to worry about MRSA as much as you do. Clavulin is very broad spectrum and a great antibiotic if you don't have cultures, if you just want to treat everything but MRSA. And if your patient's admitted to hospital, we would definitely want to cover MRSA and get cultures, and we would use tazocin as a good broad spectrum antibiotic that would also cover Pseudomonas. Now, if your patient only had black skin, a black toe, a black heel, antibiotics are completely useless because once the tissue has gangrene, antibiotics can't sterilize it. So really then if it's a toe, it may auto-amputate, or you might need a surgeon to amputate. And then depending on their peripheral vascular disease, the wound itself may or may not heal depending on their circulation. So there's no role of antibiotics for dry gangrene. And especially sometimes you might have a patient with a black heel. The surrounding tissue around the blackness might be pink. That's really inflammation and not infection. So I would definitely not recommend antibiotics for dry gangrene. Next slide, please. So we want to take into account how severe the infection is, if we can get any microbiology, and then also the patient preferences. So a patient may not want IV antibiotics. We have to listen to our patients because we want them to be compliant with their treatment. They may have had an antibiotic before. Maybe they had cloxacillin and they couldn't tolerate it because of GI side effects. So we really want to talk to our patients about their antibiotics. And especially with osteomyelitis, which is a 6-week treatment, we want to ensure that our patients know that if they have side effects of the antibiotic, that they need to call us to make sure we switch their antibiotics, because no one's going to be able to take an antibiotic for 6 weeks if it causes diarrhea or nausea or even itchiness. Next slide, please. And then education. So I know we're running out of time and I want to leave some time for questions, but it's super important that we educate our patients about footwear, about looking at their feet and who to contact if their foot is worse. We want to leave people with the tools to empower them to take care of themselves and know that there's someone around and what to do if something gets worse. And of course, we want to educate them about their diabetes and the importance of glucose control. Next slide, please. So we want people to look at their feet. This is a great pamphlet telling people about how to inspect their feet, about not walking barefoot, keeping your skin dry, looking at the bottom of your foot if you live alone with a mirror, and to make sure your shoes don't cause any blisters. We also want to empower people to know what's going to happen next. So as their ulcers, or if they have a black toe, we need to warn them that things may get worse so they know what to expect when they have a foot wound. Next slide, please. And then just as a final reminder, when do people need to come to the hospital? If they're too sick to take oral antibiotics, that's easy. They need to come to hospital so they can get IV antibiotics. You know your families, hopefully you'll be seeing them on a regular basis. So if someone looks systemically unwell or they're vomiting, if they look unwell, you need to send them to hospital. If you can't incise an abscess, then they need to go to the hospital so a physician can do it. Hand infections are quite worrisome because when we have infections, as you know, in your legs, they get quite swollen. There's a lot more room in your leg for swelling, but hands, we don't have room for so much swelling. Hand infections can be quite complicated. So not a simple blister or infected ulcer on the hand, but if you have a complicated hand infection, they really need to be seen by a physician or a plastic surgeon. If there's gas or crepitus in the soft tissues, crepitus sounds when you're pressing on the skin, there's air in the skin, so it sounds crinkly. You want to send them to hospital. And as I mentioned, if a limb is cold, white, and has no pulses, you want to send them into the hospital. Next slide, please. And then just in terms of other information from this is actually from a low-income African-American population where they looked at effective ways of preventing amputation. And the biggest impact was actually just routine follow-up. So they divided patients into 4 categories based on how they were in their diabetes. And based on that and what kind of wounds they had, they decided on the follow-up. So this is just a rough guide of what you should be doing early with your diabetics, about education, about proper shoe, follow-up with a yearly foot screen and the importance of nail and skin care. And then as people get progressively worse with their diabetes, as they get more neuropathy, following them up more often. So this is easy to say and might not be so easy to do, but when you have a lot of patients, it's a good idea to know how often you should be following them up. So someone who is more advanced with their neuropathy and with wounds, you really want to follow up more closely. And there's a lot of prevention we can still do early. Really, prevention is key. So just being able to follow up on people is really important. Next slide, please. And then I just wanted to let people know, I'm not sure they're aware, but in Saskatchewan, there's a dermatologist who is doing the second Indigenous Skin Spectrum Summit this June. So tickets are like $60 to $80. If there can be a way to at least send someone from this group to that educational session, I think it would be most informative. It's on a Saturday, unfortunately, but even one person is going to be virtual. It would be a great opportunity to hear about from experts. I think it's mostly dermatologists, but about skin issues in Canada's Indigenous communities. So I've just put the website on the bottom so people can look into it. And it's a great website as well, just with more information and resources about Indigenous skin health. Next slide, please. So I just wanted to say thank you, Miigwech, for having me here today. This is a poem I found when I was researching for another talk. I did some outreach to Indigenous communities living in Scarborough about COVID vaccines. And I think it's just very important for us to acknowledge the earth that we're on. And we know the sort of idea of 7 generations, leaving the earth for 7 generations ahead of us, the way we have the earth now. But I'm also hoping this is an opportunity of collaboration with our Scarborough Hospital for 7 generations to come, that we continue to work together to support our Indigenous communities. And with that, I'm happy to open up for questions, and maybe someone can read the chat just to educate us all about some of people's experiences with our communities and what they've seen in terms of MRSA and how they've been managing skin infections. And you can let me know if you think it would be helpful to have another talk where people share some pictures of patients and we can talk about some cases. So I'm just going to pause there, and I'm going to read just on my own some of the chat questions. And if people have more questions, they can just raise their hand and speak or add them to the chat.